Welcome to Language Clinic. We are going to talk about a very common but sometimes rare psychiatric disorder or psychiatric disease or psychological disease. And this is called body dysmorphic disorder. We will talk about in brief about the body dysmorphic disorder, and we will also talk about the epidemiology, or that means how common is the disease body dysmorphic disorder. We will also talk about the causes or etiology of this disorder, and we will also talk about how to diagnose, or we will talk on the diagnosis of this disorder. And this body dysmorphic disorder can be diagnosed in a different way, so the differential diagnosis also will be talked about. We will also talk about the course and prognosis of body dysmorphic disorder, and then the treatment plan of this body dysmorphic disorder, and then the relation to plastic surgery with body dysmorphic disorder will also be talked about. So I hope you do enjoy listening to this lecture. Body dysmorphic disorder is characterized by preoccupation with an imagined defect in appearance that causes clinically significant distress or impairment in important areas of functioning. If a slight physical anomaly is actually present, the person's concern with the anomaly is excessive and bothersome. The disorder was recognized and named dysmorphobia more than 100 years ago by Emil Kripalin, who considered it a compulsive neurosis. Pierre Janet called it obsession de la honte da corpse, that means obsession with the shame of the body. Freud, that means Sigmund Freud, wrote about the condition in his description of the wolfman, who was excessively concerned about his nose. Although dysmorphobia was widely recognized and studied in Europe, it was not until the publication of the third edition of the Diagnostic and Statistical Manual of Mental Disorders, or DSM-3, in 1980 that dysmorphobia, as an example of a typical somatoform disorder, was specifically mentioned in the US diagnostic criteria. In the fourth text revision of DSM, or DSM-4 TR, or the condition was known as body dysmorphic disorder because the DSM editors believed that the term dysmorphobia inaccurately implied the presence of behavioral pattern of phobic avoidance. In the fifth edition of DSM-5, body dysmorphic disorder is included in the obsessive compulsive spectrum disorders due to its similarities to obsessive compulsive disorder, or OCD. Now let's talk about the epidemiology, or how common is body dysmorphic disorder among the common population. Body dysmorphic disorder is a poorly studied condition, partly because patients are more likely to go to dermatologists, internists, or plastic surgeons than to psychiatrists for his condition. One study of a group of college students found that more than 50% had at least some preoccupation with a particular aspect of their appearance, and in about 25% of the students, the concern had at least some significant effect on their feelings and functioning. DSM-5 reports a point prevalence in the United States of 2.4%. Available data indicate that the most common age of onset is between 15 and 30 years, and the women are affected somewhat more often than men. Affected patients are also likely to be unmarried, body dysmorphic disorder commonly coexist with other mental disorders. One study found that more than 90% of patients with body dysmorphic disorder had experienced a major depressive episode in their lifetimes. About 70% had experienced an anxiety disorder, and about 30% had experienced a psychotic disorder. Now, let's talk about the etiology or the causes of body dysmorphic disorder. The cause of body dysmorphic disorder is unknown. The high comorbidity with depressive disorders, a higher than expected family history of mood disorders and OCD, and the reported responsiveness of the condition to serotonin specific drugs indicate that in at least some patients, the pathophysiology of the disorder may involve serotonin and may be related to other mental disorders. Stereotyped concepts of beauty emphasized in certain families and within the culture at large may significantly affect patients with body dysmorphic disorders. In psychodynamic models, body dysmorphic disorder is seen as reflecting the displacement of a sexual or emotional conflict onto a non related body part, such as association, and association occurs through the defense mechanisms of repression, dissociation, distortion, symbolization, and projection. Now, let's talk about how this disorder called body dysmorphic disorder is diagnosed, or the let's talk on the diagnosis of body dysmorphic disorder. The DSM-5 or diagnostic criteria for body dysmorphic disorder stipulates preoccupation with a perceived defect in appearance or overemphasis of a slight defect. It also stipulates that at some point during the course of this disorder, the patient performs compulsive behaviors like mirror checking, excessive grooming, or mental acts like comparing their appearance to that of others. The preoccupation causes patients significant emotional distress and markedly impairs their ability to function in important areas. Now, let's talk about the clinical features of body dysmorphic disorder. The most common concerns involve facial flaws, particularly those involving specific parts, the nose. Sometimes concern is vague and is difficult to understand, such as extreme concern over a scrunchy chin. One study found that on average, patients had concerns about four body regions during the course of the disorder. Other body parts of concern are hairs, breast, and genitalia. A proposed variant of dysmorphic disorder among men is the desire to bulk up and develop large muscle mass, which can interfere with ordinary living, holding a job, or staying healthy. The specific body part may change during the time a patient is affected with the disorder. Common associated symptoms include ideas or frank delusions of reference, usually about persons noticing the alleged body flow, either excessive mirror checking or avoidance of reflective surface, and attempts to hide the presumed deformity with makeup or clothing. As many as one third of patients may be housebound because of worry about being ridiculed for the alleged deformities, and approximately one fifth of depressive disorders and anxiety disorders are common, and patients may also have traits of OCD, schizoid, and narcissistic personality disorder. Now, let's talk about clinical practice of a patient. Miss R, a 28-year-old single woman, presented with the complaint that she is ugly and that she feels others are laughing at her because of her ugliness. In reality, Mrs. R was an attractive woman. She first became preoccupied with her appearance when she was 13, when she became obsessed with her facial defects. Her nose was too fat, her eyes were too far apart, Up until this point, Miss R was confident, a good student, and socially active. However, her fixation on her face caused her to socially withdraw and have difficulty concentrating in school, which in turn had a negative effect on her grades. Miss R dropped out of high school and went for her GED due to her preoccupation. She began to frequently pick at blemishes and hairs on her face. She frequently checked herself in mirrors and other respectively surfaces like spoons, windows. She found herself thinking about her defects almost all day, every day. Despite reassuring comments from family and others, Miss R could not be convinced that there was nothing wrong with her appearance. So, this is the example of body dysmorphic disorder. Now, let's talk on the differential diagnosis, how this body dysmorphic disorder can be diagnosed in a different way. The diagnosis of body dysmorphic disorder should not be made if the excessive body preoccupation is better accounted for by another psychiatric disorder. Excessive excessive bodily preoccupation is generally restricted to concerns about being fat in anorexia nervosa, to discomfort with or a sense of wrongness about his or her primary and secondary sex characteristics occurring in gender identity disorder, and to mood congruent cognitions involving appearance that occur exclusively during a major depressive episode. Individuals with an avoidant personality disorder or social phobia may worry about being embarrassed by imagined or real defects in appearance, but this concern is usually not prominent, persistent, distressing, or impairing. Rifat Hossein, it's enough. Why it's enough? I don't understand why it's enough. Okay. Tazin Koushufu diagnosis in Japan is similar to social phobia but has some features that are more consistent with body dysmorphic disorder. Body parts that are offensive to others. Although individuals with body dysmorphic disorder have obsessional preoccupations about their appearance and may have associated compulsive behaviors like a separate or additional diagnosis of OCD is made only when the obsessions or compulsions are not restricted to concerns about appearance and are ego dystonic. An additional diagnosis of delusional disorder, somatic type, can be made in people with body dysmorphic disorder only if their preoccupation with the imagined defect in appearance is held with a delusional intensity. Unlike normal concerns about appearance, the preoccupation with appearance and specific imagined defects in body dysmorphic disorder and the changed behavior because of the preoccupation are excessively time consuming and are also associated with significant distress or impairment. Course and prognosis of body dysmorphic disorder. Body dysmorphic disorder usually begins during adolescence, although it may begin later after a protracted dissatisfaction with the body. Age of onset is not well understood because variably a long delay occurs between symptom onset and treatment seeking. The onset can be gradual or abrupt. The disorder usually has a long and undulating course with few symptom-free intervals. The part of the body on which concern is focused may remain the same or may change over time. Treatment of the body dysmorphic disorder. Treatment of patients with body dysmorphic disorder with surgical, dermatological, dental, and other medical procedures to address the alleged defects is almost invariably unsuccessful. Although tricyclic drugs, monoamine oxidase inhibitors or MAOs, and pimozide or ORAP have reportedly been useful in individual cases. Other data indicate that serotonin-specific drugs, for example, clomipramine and fluoxetine, reduce symptoms in at least 50% of patients. In any patient with a coexisting mental disorder, such as a depressive disorder or an anxiety disorder, the coexisting disorder should be treated with the appropriate pharmacotherapy and psychotherapy. How long treatment should be continued after the symptoms of body dysmorphic disorder have remitted is unknown. Augmentation of the selective serotonin reuptake inhibitor or SSRI with clomipramine, buspirone, buspirone, lithium, and methylphenidate or antipsychotics may improve the response rate. Relation to plastic surgery with body dysmorphic disorder. Few data exist about the number of patients seeking plastic surgery who have body dysmorphic disorder. One study found that only 2% of the patients in a plastic surgery clinic had the diagnosis, but DSM-5 reports the figure to be 7 to 8%. The overall percentage may be much higher. However, surgical requests are varied: removal of the facial sags, jowls, wrinkles or puffiness, rhinoplasty, breast reduction or enhancement, and penile enlargement. uh, Men who request penile enlargements and women who request cosmetic surgery of the labia of the vagina or the lips of the mouth often are suffering from this disorder. Commonly associated with the belief about appearance is an unrealistic expectation of how much surgery will correct the defect. As reality sets in, the person realizes that life's problems are not solved by altering the perceived cosmetic defect. Ideally, such patients will seek out psychotherapy to understand the true nature of their neurotic feelings of inadequacy. Absent that, patients may take out their unfulfilled expectations and anger by suing their plastic surgeons, who have one of highest malpractice suit rates of any specialty, or by developing a clinical depression. So that's all about body dysmorphic disorder. Thank you once again to all you all for Firdos Mia. Hi Lulu Bhai. Now I am live on a psychiatric disorder, a body dysmorphic disorder. So, after a few moments, we are going to be live on some psychiatric topics, and I hope Firdos Mia is with us and he will be listening to this. There are many kinds of diseases in psychiatry. So, ফেরদৌস মিয়া, আপনি একটু অপেক্ষা করেন, একটু পরে আমরা লাইভে চলে আসতেছি। এই লাইভে আমরা অনেকগুলো বিষয় নিয়ে কথা বলবো, আশা রাখি আপনি আমাদের সাথেই থাকবেন। তো ভালো থাকবেন ফেরদৌস মিয়া। রিফাত হোসেন বলেছে ইটস ইনাফ। তো সবাইকে অসংখ্য ধন্যবাদ। এরপরের লাইভটি দেখার জন্য অনুরোধ করছি। সবাইকে ভালো থাকবেন। আসসালামু আলাইকুম।